we're very fortunate to have Mark Boschelli present to us tonight on the behavioral health programs at the Santa Fe County Adult Detention Facility. Mark received his master's degree in counseling psychology and is pursuing a doctorate in counseling education at the University of Mexico. He is currently licensed as a clinical counselor and an addiction counselor. Mark has presented at national and international conferences on mobile crisis teams partnered with law enforcement and on substance abuse and mental illness at corrections conferences. Mark is employed at the University of New Mexico Psychiatric Center on weekends and has been the behavioral health manager at the Santa Fe County Adult Detention Facility for the last 6 years. And with that, it's my pleasure to present you Mark Boschelli. Take it away, Mark.
Thank you. I appreciate being here to hopefully give a transparent view of what's going on here at the Santa Fe County Adult Detention Facility. And before I'll share a screen in a second, just so you know, my career has spanned the gamut of when the second wave of deinstitutionalization happened. I literally came out of my master's degree program, and that's when we started seeing homeless people on the streets, and they closed the large state hospitals. And I just sat there kind of going, oh boy, this is going to be a career-changing experience. And unfortunately, I was pretty correct going, I'm going to end up spending my career working with these individuals as a result of not transferring those funds from the closure of the state hospitals to the outpatient clinics, which was actually done in 1963 when we did the first closure of the state hospitals under the last signing bill of the Kennedy administration, where they started the community mental health centers. So Reagan said, hey, let's do this again. But unfortunately, that administration decided that it'd be better for a tax cut instead of transferring those funds to outpatient care. And right now we see the tail end of this. And when I say tail end, that is basically where I'm at, is in the jail. Just a side note, I was raised in Chicago in Cook County. In high school, I had gone through a tour of the Cook County jail system in high school because my parents were convinced that I was going to end up in jail. Unbeknownst to me, I've ended up in jail. So it all comes around. So that's how all this works. So let me see if I can share a screen here and go through the presentation. Oh, there we are. Okay. And then of course, I can just hit enter, right? Okay. So the presentation is on the behavioral health treatment, including our implementation of withdrawal management, induction, and continuation of care. And I'll explain what I'm even talking about here. Okay. Where's my... Oh, let me move this here. There it is, slideshow. Oh, did I get it? There we go, from the beginning. Okay, there we go. There we go. Okay. The Santa Fe County Adult Detention Facility, that's a picture of our place. Not many people know how actually big it is. It has a bed capacity of 602 inmates. It was designed that way. I remember because I was on the design committee for the facility, trying to advocate for mental health services at that time. And it had moved from the small facility off Airport Road, and then they're designing up this very large facility. Had a lot of questions of why we were going to do that, but that was kind of the start of let's incarcerate individuals. Currently, we average 250 to 300 inmates. Currently, we're at 300. So we're half that capacity. When I started here 6 years ago, we were more at 550, but we had that little incident called COVID-19, and hopefully I can explain what happened during that. But we house both males and females, but basically it's all adults, 18 years and above, so no juveniles are here. The average stay, when we look at our own CQI processes or continuous quality improvement processes, we find out that the average stay is 12 days. So unbeknownst to the public, everyone who comes in here doesn't just reside here forever and is totally off the streets. It's kind of quite the opposite. It's a very revolving, motion-centered place. So it's not static at all. The design of this facility is kind of in a clover leaf design. You think about the stem, and then you have these 4 leaves, or basically units, and each unit has 6 pods in it. Usually the capacity is around 25 in each one of these pods, but then the 5th unit is the medical unit, which is kind of at the ground floor of that clover leaf design. So we have both cell blocks, like you see on TV, whatever show you like to watch, Orange is the New Black, whatever, as well as we have dorms, which is an open dorm style experience for inmates. We have a full medical unit here. We have 2 medical bays, as well as we have 18 cells in that medical unit. And it's interesting that we call it the medical unit, because most of the time, the psychology department, behavioral health department, most of our inmates, when they're not doing well, end up being housed in the medical unit. But it's a medical unit set up for medical processes, but hopefully I'll explain why we do it in the way we do. Easiest way to get a hold of us is calling our front desk. We put that phone number there because not everybody can find it. And these days, now that you see the very large Santa Fe studios, we can see that right outside of our window, and we get to watch them do production. So before it was all barren land, but now it's more known for Santa Fe studios. So it's kind of interesting to watch Robert Redford walk in there and stuff. Key staff, just so, once again, for transparency's sake, our warden is Derek Williams. He is the gentleman who hired me on 6 years ago. He gave me one mandate. He said, can you make a behavioral health program here? Which is coming from the private sector of working 30 years here in Santa Fe prior for a medical corporation, just being told, make a behavioral health unit that really helps the inmates was kind of a shock. And that was coming from the leadership, both from the warden as well as from the county manager. So we actually have done that. We have a full-time psychiatric nurse prescriber. Her name, Rebecca, is who that is, Rebecca Otero Granger. So that person is available, is on site 3 days, and then via telehealth the other days, as well as on call with myself 7 days a week. Our medical doctor, we have a full-time medical practitioner, Mel Oliveras. Not many jails, first of all, don't have a psychiatric prescriber, nor do they have a full-time medical provider, but we do. In addition, we have a health services administrator, Ashley Hannon, and I'm the behavioral health manager. And secret, we have a full dental clinic here. So hopefully you're starting to see that this is a city within a city. All of these people outside of the dental, everybody is employed by the Santa Fe County. This was a decision that was made 6 years ago that the county was having trouble filling positions, like any place with workforce development issues. And they decided, let's invest, and instead of having all these private contractors, we're going to hire everybody, make them county employees, and actually improve the pay across the board. And the county has followed through with that. And subsequently, this is a fully functioning, in my view, detention facility. On the right-hand side are all the clinical staff, all of our behavioral health therapists. So we have 1, 2, 3, 4, 5. We're about ready to hire 2 more behavioral health therapists. So basically, we'll have a contingent of 6 to 7. Right now we have 6. We'll end up with 7 therapists on board, behavioral health therapists. Once again, this is the mandate from the warden through the county commission, going really make a fully functioning facility that respects the individuals who need to be taken care of. With that, we've expanded to the idea of reentry specialists. We're able to recruit successfully 2 individuals with lived experiences. When we talk about peer advocates, certified peer advocates, these individuals, both substance abuse issues as well as have resided in detention facilities. So we're talking full lived experiences. Josh Trujillo loves to, pop up his picture of his booking date because he says at that time he was very thin. He was also addicted to methamphetamines, but he likes the way he looked, but not the way he felt. But he'll be glad to show you that picture. So you start to kind of see that we have a robust behavioral health and medical staffing going on here. Some of the questions, especially, when you're concerned about your loved one who might be suffering from a mental illness, the behavioral health therapist, the roles here, primarily, we start out with suicide assessment, intervention, and prevention. None of us ever want to have an incarceral death. It causes chaos for us. It's not what we're mandated to do. We are to prevent that at all costs. So we are very sensitive about that aspect and try to make that one of our primary roles to keep people alive. It's tough when someone comes into the jail. We don't care if you've been in here numerous times or it's your first experience here. It is a traumatic experience because it's a jail. The behavioral health therapists do crisis intervention, de-escalation, and counseling support for inmates in acute psychiatric distress from coming in here. As one of our patients told us today, basically before we went online, is you've stolen me, you've taken me away from being outside. I'm a hostage now. And that person subsequently attempted to end her life, but we were successful in intervening with that. The person's more calmed down, but they're kind of right. Coming in here, the police abduct people against their will, put them in a place against their will, and psychologically, all the behavioral health therapists we've all been trained to understand working with a person in that type of position. So we do rounding for counseling need and answering inmate communications. We have, each pod has a kiosk. So they will email us messages. Sometimes they're colorful. Sometimes they're a little off base. Sometimes they're written by people on substances and they can be funny. Other times it's, a cry for help. The behavioral health therapist then will do a 14-day behavioral health assessment on each individual who stays here for 14 days. We're not mandated to do that. We're mandated to do a 14-day behavioral health assessment on people that we think has mental health issues. But when I came on board, I couldn't decide who had mental health issues, who had substance abuse issues. And so we're like, no, let's just do this on everybody and see what gets revealed. So we go above and beyond on purpose because we find a lot of more information by just kind of let's do an assessment on these individuals. The therapist will screen for appropriateness for psychiatric medications, and we will help advocate for appointments with our psychiatric provider. We'll do this verbally, asking the client. Sometimes the client doesn't know what's going on, is not able to be very good historian. But once somebody comes into our facility, we do the nurse intake will do a full assessment on the individual, a full intake, substance abuse assessment and behavioral health assessment, and then they make referrals to the behavioral health staff. but plenty of times the behavioral health staff are down in intake intervening when someone's really not doing well. The nurses have no difficulty calling us. You know, we have a therapist stationed in medical, and we're going to be expanding to having another behavioral health therapist in booking. It seems to be our most active place in this whole universe of this jail. On Wednesdays, the therapist will attend an interdisciplinary team meeting. This is not just made up words in that meeting, which literally is like a 3-ring circus. You know, I'll be honest about that. Because we have multiple disciplines, they'll start talking about someone in need or they're concerned about in different perspectives. I'll have security talking about that they're really not happy with this person because they're not following mandated objectives. Behavioral health staff will be like, well, that's because they're responding to auditory hallucinations. The psychiatric provider will be like, what medications do they need to be on? We'll even have the warden in there going, is there something else that we need to do for this person? We'll have nursing staff talking about their medical needs, their acute medical needs, as well as their chronic medical needs that aren't usually being taken care of. And then we also have our CQI director in that meeting purposely gathering data so that we can have a very good data set on the individuals who come to our facility. And then so we can adapt according to that, because we do a full CQI meeting every month. And then we do a quarterly CQI meeting, and then we have adapted our program according to our clients' needs. So it's really CQI in action. In addition, our behavioral health staff will attend our unit classification and housing committees with inmates to ascertain their mental status change due to the incarceration. We don't have isolation here, but we do have one of our pods when people don't know how to follow the mandated rules. Those individuals end up in their own cell, but we'll take them out weekly. And then behavioral health staff, as well as medical staff, as well as the security staff, will be interviewing those individuals to see how they're adjusting to that type of placement. Most behavioral health issues in a jail get overlooked when someone ends up kind of being isolated more away from the general population. So we purposely will weekly assess those individuals to head off any issues that might be percolating for those individuals. You know, if they need to be brought to the psychiatric department for medications or tweaking of their medications, we do it right there on the spot. We don't want anyone to be lingering, away out of our site. We have behavioral health programming here. All the therapy components are evidence-based. That was our mandate from the warden once again, said that, before the detention facility used to, talk about all these groups that they used to have. And sure, they had all these flowery groups, therapies, but they really weren't taking place. And so the warden said, let's just erase all that, start from the beginning, and really, if we're going to do treatment, we will tell everybody what we're doing and we will follow through with that. And he wanted to make sure that they were all evidence-based according to the SAMHSA model of treatment modalities. And so that's where we're at this time here at this facility. So give you an idea of mental health contacts. Once again, this is because we can do a lot of data-driven internally. We look at it each month. We have a lot of, sometimes the inmate communications will actually go up. It depends. I mean, Santa Fe, quite frankly, is a tourist destination for around the world. We always notice that we end up having more people during tourist time incarcerated. At that time, our mental health intake assessments kind of remain the same because, once again, not everyone stays for 14 days. But we'll do daily rounds in each pod. So we'll ask if anyone has any issues or not. Sometimes people are not in any condition to even tell us that they need this. But once again, we gather our data. We have to present our data to the county commissioners. They want to know what we're doing, why we're doing, what's behind it. We have a special day every year with the county commissioners. If a new county commissioner gets elected, and I think 2 new county commissioners have been elected, they get a special time with us to get oriented to all the activities that we have going on at the detention facilities. So we'll go in depth to give them all the information before a county commissioners meeting, so that they feel well versed in the information. This is one of our CQI findings of the percentage of inmates on psychiatric medications. You're seeing, 87% of our clients are inmates here are on some form of psychotropic medications. Here's your indicator, and I remember meeting with the warden my first 5 minutes on the job, and I asked, are you okay with running a psychiatric and substance abuse center? And he's like, no. He's like, this is a jail. And I'm like, okay, okay, I agree. But, nowadays, the warden will be the first one who will say, I think I'm running a psychiatric and substance abuse assessment center here. I'm going, yes. The psychotropic medications, just so you know, one of the reasons why the percentage has gone up is because we're doing more medication-assisted treatment for opiate-addicted individuals. And our medication of choice is naltrexone, which is an IM medication, lasts for 30 days. It's not opiate-based. So that's one of the medication-assisted treatment programs that we're part of. But that's the prescriber wanted me to make sure that people understood that. But when we do prescribe psychotropic medications, we do not prescribe anything that's addictive. So we're pretty unpopular with the inmates, just so you know. Everybody who's been on any type of benzodiazepine, Xanax, Valium, you name Ativan, who've had that in conjunction with their other medications, we stop prescribing it. After we detox them down, of course, we'll titrate them down. But one of the reasons is diversion. That becomes something that is monetary here in the detention facility. It is, if the person used it themselves, that'd be great, but that's not what happens. It becomes a monetary source to get better treatment from the other inmates. Similarly, we don't prescribe Seroquel, which is an antipsychotic medication, because that also can be diverted. We've watched plenty of people divert. They end up having behaviors done to them, sometimes, inappropriate behaviors, or buying off their own protection. So we don't prescribe Seroquel, but we'll use the other antipsychotic agents that are not in any way diverted. But we will make sure that we have a whole clinical formula of medications that we do prescribe. We do not charge the inmate for the psychotropic medications. We do antidepressant medications, antipsychotic medications, and of course, mood disordered medications. We have no difficulty with that, but our prescriber is very firm, because she spends the rest of her week like I spend my time at the psychiatric center down at UNM. She spends her time down at the DOC site in Berlin. So we have a pretty good feel of the type of clients that we're seeing from a psychiatric point of view. I bring the community mental health perspective. Our prescriber brings more of a Department of Corrections prescribing pattern. But combined, we hope that we're helping out the citizens as best we can. So behavioral treatment. The mentally ill individuals, because I thought this would be a primary focus here, they are identified at intake, whether we have a historical documentation on those individuals, whether I have knowledge of them. I've been around since '88, so most of the people with major mental illnesses I've either seen, heard of, or supervised people seeing them. But in addition, we have full electronic health records here. So we can pull that up, what we need to know about that individual. Sometimes people are very good about telling us about their medications, but the majority of times they're not good at all. So we will have prescriptions verified at the pharmacy through the pharmacy monitoring program. Sometimes we have to do a lot of detective work. Some people are they're sleeping the whole time. and we have to put on our detective caps, and we're calling Walgreens, CVS, you name it. We're backtracking all the way through the pharmacy monitoring program to kind of see if they've been seeing a provider in town. Sometimes we get snippets of information, and we're trying to put it all together. So it's, if anything, we're pretty good at trying to figure out where they were at last, what medications they're on. Any psychotropic medications of addiction or tolerance are discontinued. Like I said, once again, this is a carceral setting. It's much different than outside in the community. And if people don't understand what that means everything is used for something else. Everything, whether it's a pencil or a prescription of Ativan or Suboxone. I mean, it's just diverted. It's how this really works here in a carceral setting. So we review in weekly interdisciplinary team meetings those individuals who we're concerned about, and usually those are the people with the major mental illnesses. At that time, we're always doing on-the-spot training to security officers. This is what you see when you have this type of diagnosis. We will talk about it in depthly. Sometimes, people will say, "I don't understand. They're just fooling. They're just trying to fool us." And I'm like, "I don't think so. That's a major mental illness they're responding to." We attempt to coordinate with community treatment programs, and it's an attempt. Quite frankly, it's difficult. If anyone says it's easy, I disagree. And I used to work at one of them, and I have no context anymore. The only teams that will talk really straightforward with us here at the detention facility are the assertive community treatment teams, because they're mandated to follow their clients. They're ones with the major mental illnesses, to make sure that there's a way that when they get out, they're coordinating with us. They have no tendency. We have good relationship with the alternative response unit from the city of Santa Fe. And I praise Nicole. She'll write me an email. At that moment, it's about coordination of treatment. It is not about protection of information. It's actually, we're trying to coordinate treatment so we make it better for that individual. I'd like programs that kind of just reach out, throw us an email or a phone call. It works quite well. We get phone calls from family members. Mijito's off this medication. He hasn't been on it for a while. We'll take any information. We're not shy about this. We might not reveal everything back, but we'll receive any type of information that we need to know from family members or from other community programs. Law enforcement's pretty good when they're dropping somebody off. Literally the police department, state police department, municipalities, magistrate, sheriff's department, they will usually say, "Hey, this person was talking about killing themselves in the back of my squad car. I don't know what you want to do with that." It's okay. We take that information. We appreciate that. A number of those cadets that I used to train 2 decades ago now come in and they hand off clients to me. It's kind of funny. They've gone somewhere in their career, and I don't think I have, but they give me a lot of information. They'll say, "I remember when you were training us, we did 26 weeks of training at the law enforcement academy, and you came in for the last week and talked about mental illness and substance abuse, and you said that half of our time is going to be dealing with these individuals. We all poo-pooed you and made fun of you. We want to know how to fire our gun and do the pit maneuver with our cars. But in actuality, 50% of their time is working with people who are mentally ill or have acute substance abuse issues." So it comes full circle. You'll see how this all works out. We push these individuals to integrate into general population. We don't have a separate psychiatric ward here. There's no psychiatric pod. Purposely, it's mandated by the warden. That's his philosophy. And we've all adapted to that. At first, I wasn't sure about whether that would work, but it actually does. It helps teach community norms for individuals with a mental illness. Security is very tight on monitoring those individuals, because we'll bring them up in an individual in the IDT, in the interdisciplinary team meeting, and they will say this person is not, being able to conjugate well with everybody else. Or they'll say, surprisingly, they're showing skills of maneuvering around, understanding the politics of the pod. The reason we'll push for that is we stabilize them with their medications, but we know they're going to go back out into the community. We want them to be practicing skills of how to get along in the community. So we'll purposely not isolate these individuals. If the court orders treatment to competency, this is a big thing these days. It's restorative competency. Then they're ordered to NMBHI, where a treatment guardian can be awarded if needed. Some of our difficulty here is we will stabilize the individual with a chronic mental illness, and they'll be too good when they finally get a court order to move to NMBHI. Sometimes a treatment guardian is not awarded because they've been compliant with medications here at the detention facility. And then all of a sudden we're like, oh no, we needed a treatment guardian. And they'll make their own assessment, even though they get all of our medical records. So sometimes we will kind of lay low with some of the medications because we know they're going to go to NMBHI for a competency review. We want them to see the individual in full-blown form of not doing well. So a treatment guardian will be awarded without any questions. Because eventually, after this restorative competency happens, they come back to the detention facility. And then what that means is they're able to understand and participate in their lawyering experience to remedy their case. And we want a treatment guardian awarded so we can keep the medications going. And if they choose not to, if they don't have a treatment guardian, they'll go off their medications and it'll double the time period of them being here at this facility. I personally don't think that people should be at a detention facility to be restored to competency waiting for a bed at NMBHI, which is supposed to take basically a month. But we see 6 weeks to 6 months waiting period of time to go to the forensic unit. That's a disservice to someone with a mental illness. This is not a psychiatric hospital. It's still a jail. But it's uncomfortable for us that they might wait that long to go to NMBHI. We have most of our success with mentally ill individuals, linking them to assertive community treatment teams. There's 2 now in town. We've started be able to get referrals to the second new assertive community treatment team, the wraparound service delivery system, outpatient wide. I was working with the county when they asked, what do you think is needed? And surprisingly, because I'm at the detention facility, but the county asked what else is needed on the outpatient basis. And I said, another assertive community treatment team. And so the other part of the county, the community service department, was able to get funds to help initiate that assertive community treatment team. And I wanted to make sure that that actually was going to be judicially involved individuals. So I just didn't want the worried well on that team. I wanted the judicially involved individuals so they stopped coming in here. Across the board, the whole county has adapted the idea of decreasing recidivism here at the jail. This comes down from the county manager down to all the components of the county. So I'm on one part of the county, the public safety division. The other part of the county is the community service department. But the county manager has ordered and successfully ordered that they will work together. And the goal is to decrease recidivism and to meet the needs of our community members. So as a result, last year, we had to write a grant. I wasn't so thrilled about it, but I helped participate and wrote a grant to the Bureau of Justice Assistance and SAMHSA, and we won a Building Bridges grant. We were one of 15 sites around the nation, jails that were seen as potential peer sites that was shown the propensity of doing good treatment. And so we got chosen as one of those 15 sites, and we've been back and forth to Washington showing. As a result, they made us write out our goals. So I had to go through kind of the Santa Fe as well as Santa Fe County, as well as statewide, all of our issues about medication-assisted treatment here at this jail. At that time, We were not welcoming medication-assisted treatment for opiate-addicted individuals. We wanted to really have people stop taking substances, but we had to really take a hard look at this and look at our data. And if you think about it, in 2023, 3,200 inmates submitted UAs at intake, and almost 91% were positive for one substance, 73% for two or more substances. This is our own data. In 2023, 55% were positive for fentanyl, 51% for amphetamines, 78% for a combination of methamphetamine and fentanyl. Just so you know, we're just kind of giving you the snapshot of who we really see here. So we have a huge substance abuse and mental health issues going on here. So when I say that the warden now says with glee, we have a very large substance abuse and psychiatric center here. And I'm like, okay, I understand why I'm here now. This makes sense. It's come full circle. Important to us was that we found 64% of our detainees were released within 96 hours of booking. They had their intake, they've been assessed by behavioral health, but then they're just let out. Linkage to other services, basically non-existent. So we made our goal for the federal grant was to help stimulate community continuum of care after release from jail. And this grant was written in partnership. I wrote this in partnership with the community service department. So you have the full county's weight behind this. So we have accomplishments. Here we have a lot of things going on, a lot of evidence-based practices. We actually have 12-step NA and AA meetings. They were all via Zoom during COVID-19, but now they're all being taken place here face-to-face. Basically trying to teach people, if you have substance abuse issues, you need to practice going to a 12-step group so you have additional support upon release. So we start having them practice this behavior while they're here. We've added medications of opioid use disorder participants to our weekly established interdisciplinary team meeting. We have a full opioid overdose reduction plan. We give out didactic and video presentations of how to use Narcan. So people can sign off, okay, I understand. And it's not so much to help that one person who might be taking the opiates themselves, but to help their loved ones. So we have a way to infiltrate the family systems. We give them a Narcan toolkit upon release, basically a 2-dose Narcan rescue kit, hard given to them. We don't give them a script. We don't tell them to go to Walgreens and CVS and go pick up Narcan. It's a lovely idea. I know the feds have all come up with this as well as the state of New Mexico, but it just doesn't happen. But by giving and putting it in their possessions, and they take their possessions and leave this facility, it gets to their family systems. And we're just like, just put it on the kitchen table. It's okay. So if someone's, had overdose using their fentanyl, at least a family member can dose them up with Narcan and save their lives. We do a lot of administration of Narcan in our booking area. We have a lot of code blues. That means people get picked up by law enforcement. And then what we see is they swallow all their material that they have on board because they don't want to be arrested for having illicit drugs. So they swallow it all. Or they put it up body cavities. And what happens is it either leaks out of their body cavities into their bloodstreams, or what happens is they look fine. They've been medically cleared at both the emergency rooms, brought in by the sheriff's department, and then they code on us. So that's where we have the largest administration of Narcan is in our booking area because we don't know who these people are. They're not stabilized in our facility yet. So we're doing a great deal. We average around 8 Narcans, bringing people back from basically death on a weekly basis. Unfortunately, none of that gets press. We understand that, but that is a huge life-saving measure that the nursing staff is doing on a regular basis. We don't even flinch. We're kind of like, of course, let's go do it. And it worked quite well. With the fentanyl, it's a little bit stronger. It's taken more Narcan lately than before. We have one of our evidence-based programs that's getting national notoriety is our Matrix program. It's a 30-day treatment program. It's a volunteer treatment program. You have to volunteer and fight your way to get into this program. In other words, you have to go through a vetting process. We have to make sure people can get along with each other, as well as, are you committed to really working on your substance abuse issue? This is idle time. You're here. Basically, you're going to see the same thing at Santa Fe Recovery as you see here. We're going to save you a bunch of money. Why don't you do your treatment now? We're selling this on a daily basis to every member that we can. We're currently in a summer class right now. Usually it's around 80 participants want to be in it. It gets vetted down to 50, then it gets vetted down to usually 15 individuals can actually make it through the program. It's a modified therapeutic community. In other words, they get their own pod. They're separated. They're separate pods for men and women. We do cognitive behavioral therapy. This is a curriculum for offenders with substance abuse disorders. So it's specific to these individuals who are here. We find out that a number of people who have co-occurring disorders, mental illness and substance abuse, have done quite well because it's very structured. And surprisingly, when our ability to predict who goes through this program successfully is quite poor, quite frankly. So we've given up predicting who's going to make it, because the people who look like they're going to make it don't make it. The ones who don't look like they're make it, they're very successful. So we've given up. We engage individuals with substance abuse disorders in treatment to help them achieve, the goal is to achieve abstinence from substances. The focus of this clinically is we're trying to get them to think. And most of the time, these individuals will say, usually during their second week of this treatment program, this is the first time I've been sober since 6th grade. So then they start thinking, you start seeing the healing process going on in their brain. So we have statistics, a lot of statistics. Basically, all we're trying to really tell you here is that compared to no treatment at all, we usually have a recidivism rate between 80 and 90%. With treatment, it's only basically a little bit less than 30% for both males and females coming back into this facility. So we're not saying that we have the panacea for treatment and curing opiate disorders, but we notice 2 standard deviations. This is a big change compared to no treatment at all. And I've given this presentation on a national level at correctional conferences, and they're kind of like, isn't that hard to do at a jail? Because this is not a static population. We have all these people circulating through, and we're trying to figure out who can go through this program and stay in this program. So we have stats from 2023 compared to 2024. What we find out is that with the Matrix program, it holds for a year before we start seeing declining of the treatment upon the person. So after a year, I don't know whether it's the community that they go back to, we find a lot of difficulties that they'll start using again. But the first year, we start getting some really interesting results. So basically, the county manager asked, what do you need after that? And we sat there one day, and this was 2 Novembers ago, and the warden was in the meeting. He says, well, what do you want? I go, well, after they're done with the Matrix program, they don't want to go back into population. They want to keep out of population. And so we set up a reentry pod. That's where we have graduates of the substance abuse program, and then we go through other evidence-based practices such as seeking safety groups, anger management, circle of security, to help people parent. Because remember, these are individuals who have probably been isolated and alienated from their family systems. They want to become parents again. So we're teaching them parenting routines in the circle of security classroom. A lot of anger issues. So we follow a SAMHSA anger management modality. And then seeking safety once again, because when you think about why these people are coming to jail, and it's usually because of the historical trauma of their own family systems. Maybe they've been sexually abused, they've had physical abuse. Just trying to take a trauma-informed approach to this and be realistic. This is why they're here. They're not terrible people. They've just had some terrible experiences. So After that, we did town meetings, and the county manager asked once again, what's needed? You start to learn never to ask us that question, because we'll come up with an answer. And we said, working with LifeLink, and at that time we had LifeLink coming in doing reach in case management with us. And then LifeLink came up with the idea, how about we have a house for these individuals to go to, because housing was the biggest issue after recovery from substance abuse addiction. And the individuals were afraid to go back into the streets and start using again. So the county service department decided to fund the Rise House, which is actually a house here in Santa Fe. I'm not going to tell you where it's at, because we're not allowed to have group homes. NIMBY is all over the place. In other words, not in my backyard. But we've been successfully, the county has funding the Rise House. We have people that go through the Matrix program, the reentry pod, and then can go into the Rise House. So we have housing for these individuals. And then as we asked them, because we keep on having these town meetings, and kind of foolish on our part, or we're actually trying to catch the pulse of the individuals in need. We asked, what else do you need? And they said, well, we need training for jobs. We need to get our IDs again. We need to try to get our driver's license. We need access to healthcare, all these type of things. And all that is part of the Rise House. And then the county has just started a new initiative. It is called, in fact, I have to look at it. It's called Work Links. It was a grant that we put together, and it was awarded to Innovate and Educate to actually help individuals who've gone through these different components, who are in the Rise House, to seek and be able to be mentored into county positions, Santa Fe County jobs. So it's my joke that, oh my God, I'm going to run into all of our patients as they have jobs with the county, but it's serious employment. Not just rinky-dink employment of part-time work. We're talking about mentoring into full-time employment with the pay of a county employee, with the benefits of a county employee, and to fill hard-to-reach positions, such as working at the food kitchens and senior centers to learn how to be a sous chef, to become a chef, to working, some jobs working in maintenance. But these are all hard to fill positions that the county has not been able to fill due to manpower shortage. And we're like, we have all these people. So the county manager came up with this idea during one of our graduations. I personally was quaking in my boots when he said this. I was like, oh my God, I cannot see how this is going to work. However, we have started the program, and we have our first pilot of an individual who's going to behavioral health meetings in the leadership committee. They're having trouble recruiting, retaining licensed professionals, licensed staff. This is also creating gaps in services. So that's why we want to really try to establish a continuum of care service delivery system. So this is what we've done new. We've implemented a MAT treatment withdrawal management program. We've been basically deemed competent by the Bureau of Justice Assistance, as well as SAMHSA, as well as DEA. We're about to get our second national grant from Building Bridges. It's to be awarded any day. We have started a MAT, a medication-assisted treatment program, an induction program. So people who are on opiates, which is basically, as you saw in our statistics, around 74 to 85% of our individuals coming in, they're going through withdrawals. We're going to help them out with Subsolve, which is basically a buprenorphine to help their withdrawal symptoms over a week much more comfortable. If they're much more comfortable, they're going to be willing to talk and engage into services. We're once again building that continuum of care post-release from jail. We're not thinking that, hey, go out the door, we don't care about you. We're going to build it. We decided that we have to participate. We have to be the linchpin that's helping these individuals. We are also in the process of integrating the local courts with the here at this facility and the community programs. In other words, I know with the NAMI programs, there's a big push for the assistant outpatient treatment. That's the whole idea. If there's going to be some of that reinforcement of making that actually happen with the black robe effect of get back on your medications, we'll withdraw the charges if you get on your medications. I think I'm all in favor of that. I know it talks about people's, rights of those individuals with major mental illnesses not to take their medications, but quite frankly, we have a lot of luck putting people on IM medications, long-acting 30-day medications. We've seen a lot of stability. So, I'm basically someone who's basically advocating so that we start using more of the outpatient assisted treatment program, so that once again, we could decrease recidivism and help these individuals have a better life. So, we're about ready to, probably get awarded. I can't say we have it yet, another $250,000. And, that we're going to hire another lived experience certified peer support worker to help us down in medical and booking. Because once again, 64% of our population leaves within 96 hours and no one touches them other than the clinical staff. But we think they need to be linked up to services. So that's what we're trying to do. We've used the non-opiate based buprenorphine medications, or non-opiate based and buprenorphine. We do a lot of push for naltrexone. It's not opiate based. We start out orally and then we'll give them a 30-day injection. We like the effects, takes down the cravings. There's no opiates in it. And then if we do start somebody, we're going to use the Subsolve to bring them down from their withdrawals. And then if they want to stay on a medication assisted treatment that is opiate based, we're going to do Sublocade. And we've already started this. Once again, that's a 30-day injection. There is no chance that it can be diverted amongst the rest of the staff. I mean inmates, sorry, not staff, to inmates. As a result, security has been in favor of this. So these are large changes going on here at this facility. So
Great.
how do let me get out of this. I'm going to stop sharing here. Yay, I did it. I pressed the right button.
Mark, thank you so much for a really comprehensive and a bit overwhelming presentation. You guys are up to. No, that's fine. It was just really impressive what you're up to, and a lot of us are aware of the challenge of doing that of what you do with the population and the short amount of time really you have to do it in a lot of ways. I was really surprised not only to hear that the average stay is only 12 days, but 64% or whatever, they're only 4 days.
Yeah.
And that relates to a question that Nicole has related to the Matrix program, which of course, as you mentioned, is a 30-day program. How can individuals needing access to the Matrix program access it if they get released quickly? She'd like to advocate for people to get your services related to the Matrix program.
All right. For that, we've had individuals who will start in the Matrix program and then we find out they're going to be released. The judges do that a lot of times. We've kept them in the Matrix so they can at least get some experience of the Matrix, because currently right now, Santa Fe Recoveries is using the Matrix material. I know Tierra Nueva Counseling Center out of Southwestern College is using the Matrix program, so that there's a common language, so that we're trying to basically make it so it works. But it works better for 30 days. So I don't have anything totally for short term. I have to be honest with that.
Thank you. Cam has a question. Are individuals sent back to the community with a supply of the medications they have been taking while in the facility?
Yes. Unfortunately, we will send a script to Walgreens on Richards. We have a contract with them. The difficulty, once again, is not many people know how to go to the pharmacy to pick up a script. But yes, we will send a script, and we will cover that cost. Once again, a lot of these people, their Medicaid is not turned off because they've gone through this system. Medicaid hasn't caught on to basically put it in stasis. So their Medicaid is still good. So we will send that script. Yes, we have no difficulty with that. And sometimes we get phone calls back when someone says, I told you, to shove it with those medications, but actually I need those meds. And we've been known to send that script over to Richards. In other words, not pass any judgment. we all make rash decisions at times. So we've sent plenty of prescriptions to Walgreens for individuals who have already been discharged from us, just so that we can bridge that gap between medications.
Great, thank you. Jessica asked a very compelling question, in my opinion, and her question is: are there any emotional support services available for the staff of the detention facility, such as the corrections officers, etc.?
Yeah, we have an IOP. We have contract with the Solutions Group, and I do training. I'm part of the professorship here. I train all new cadets on mental illness, substance abuse, but also how to take care for yourself. So the county does invest in an IOP program that's no cost. I believe it's 3 sessions free. We push for correctional staff. Please utilize this. We want you to stay on board for a long period of time. It works better for all of us. If you have substance abuse problems or marital problems, please do that. So it's widely discussed in their training, and they go through a 40-hour academy training here. I'm sorry, it's 6-week academy training. And I think I do 18 hours with every cadet about mental illness and substance abuse.
Great. Thanks, Mark. I have a sort of an open-ended question, and that is, with the population you have, and also the varying frequency of how long they're there, and 4 days, 12 days, some of them a couple of months maybe. What do you think is the biggest challenge or challenges in what you're trying to do in the behavioral health world for them?
Well, at first, I was the staff. And I asked HR, are you going to help me hire staff? And they said, no. It was kind of straightforward discussions. And so I started a whole internship program. I have a relationship with 5 different universities at this time. As a result, all of the people who are on staff now, we're up to 7 behavioral health therapists, have gone through a 6-month internship with us. Through their universities, I have to do a lot of talking to different professors and all that type of stuff. But as a result, the people, this is how we've solved our workforce development issues. We made our own workforce. It's extra time, hard work. However, by being transparent, people want to come on board. And we've been very successful. I'm very pleased with all the graduates who've come on board. They know things better than me. I'm the one who just cracks jokes and tell bad stories, but they're doing all this hard work and seeing what it's like to be involved with a hard to treat population, but we do it well. We have a lot of fun, believe it or not. This is a jovial crew that works here. We've seen what we're doing for the community. So that makes it fun. That was our biggest challenge. The second biggest challenge lately was the movement towards medication-assisted treatment for opiate-addicted individuals. The administration did not want to work in that direction. I'm on the fence. On a good day, I'm in agreement. On a bad day, I'm not in agreement. But by having an abstinence-based program of treatment here, we feel very good with it. We see good results, but at the same time, we're being respectful to those individuals who do need to be on a buprenorphine type of medication post-release so that they stay alive, because we don't want people overdosing as soon as they're out of here. So those have been the biggest challenges that I've seen.
Yeah. Thank you for that. We've got time for maybe 1 or 2 more questions, and I'll start real quickly with Nicole has a very specific question, which is, how long does an inmate need to be on Subsolve to transition to Sublocade?
Yeah, we will do a 7-day taper, and we're just starting that this week, to be absolutely honest. So we're just trying to get it ordered to get going. So after that, they'll be transitioned to basically being clean. They withdraw permanently. And then if they say, hey, I want to be on Sublocade, we then say, okay. And this is, almost killing us, but we're like, okay, we will do it. So it can be immediately after their withdrawal induction process of the Subsolve. This is a big new behavior. However, the security is comfortable with the Sublocade in the population because no one's diverting it. It's, you know, injected into the abdomen area. You can't take it out. And diversion is like the biggest thing. And if you work and you figure out a system that gets past diversion, so no one's abusing or overdosing back in the general populations, security has been very, very supportive of this process.
Great, thank you. Seeing no other questions, I'll ask the final one, which is, and I know it varies, Mark, but how would you characterize how receptive the
Greg.
clients are? Oh,
Sorry.
did you have your hand up, Eddie?
Well, I had one in the chat.
Oh, okay.
Oh.
I'm sorry, I missed yours in the chat. So go ahead and ask it.
Oh, okay. I
for
don't know
it.
if you're going to read it.
No, I didn't see it. So go ahead and just ask
So
it.
at our NAMI, sorry, I just wanted to know, at our NAMI convention, we heard that there are some states that have asked for waivers from CMS for Medicaid waivers to allow inmates to have their Medicaid reactivated before they're discharged. Do you know where we are on that in New Mexico?
Yeah, it's called 1115 waiver. I know too much about this, unfortunately. We are still, it has not been awarded yet, but it's supposed to be awarded. But remember, here at the detention facility, most people don't end up with their Medicaid being turned off. You know, we seem to fail to call Medicaid and say, you better turn that person's Medicaid off. We seem to not know how to make that phone call.
Well, that's
kind
cool.
of on purpose. I know, yes, it's, you know, it's a deficit of knowledge on our base. But in other words, we want to keep their Medicaid going so that it's a flow, so they can get picked up by another agency that has Medicaid, you know, reimbursement. But we're going to find out soon. New Mexico has not been awarded it yet. But, you know, there's parts that are positive with that and negative. I'm going to be honest, the negative part with that for us is at this time, the county is really robustly funding all of our programs here. I really don't want the county to kind of go, okay, forget about that funding. Let's just build Medicaid. And if you've ever built Medicaid, you find out that there are some hazards to that and oversights and billing, and you have to have other staff. I kind of like not having to think about that personally.
But you're saying you don't deal too much with Medicaid. I mean, there's
Well,
not stuff that they fund. Well, people
Medicaid funds, if someone goes in the hospital for over 24 hours, Medicaid will fund that, even though they're a detention facility client.
Okay.
They will fund outpatient clinic for specialty clinics. We already do all that to bring someone to get a wound recovered from, you know, a gunshot wound. So Medicaid already does all that. The 1115 waiver is focused on reentry back into the community. We already have a robust reentry program going on. And then there's some talk of some housing supports, which probably might be interesting for individuals coming out of a detention facility. And also detox, to pay for the detox program and the detox medications. That's what the 1115 waiver would pay for.
Okay, thank you.
All right, with that, I think we'll wrap it up. Once again, Mark, thank you so much for both presenting to us and for all the wonderful work you're doing at the county detention facility and the staff that you work with there.